Thank you, Dintanak. Thank you for the kind introduction. It's an honor to be here. And I also would like to express my condolences for the loss of your beloved late king. So I think you have seen in the previous two presentations the virus side and the HIV reservoir and what are the strategies to cure this HIV reservoir. So what I will try to do in the next 20 minutes is to bring you to the other side of the coin, which is the immune system, and what can we learn from the studies we look at the immune system and the immune response against this HIV virus, and how can we implement immune strategies to cure this HIV. So in the immune system, there is different types of immune cells that can really try to eliminate the virus. And as you can see in that picture, we have many different types. The dendritic cells are sensing the virus and then are secreting antiviral molecule to attack the HIV-infected cells. We have also B cells that are secreting antibodies that can capture the virus and that can also recognize HIV-infected cells and mediate other type of cytotoxicity. And we have also the natural killer cells, the NK cells, and the CD8 T cells that secrete little granules that can really directly kill the HIV-infected cells. So we have different ways in our body to try to eliminate those cells. The virus is really targeting the CD4 T cells, and most of our cells that are infected in the body are CD4 T cells. And the CD4 T cells in the immune system are actually the master regulator of the immunity. So these cells are really interacting with all the different cell types, as you can see here with all these arrows, and they provide help to all these cells to provide a good immune response. And so when the virus is infecting those CD4 T cells that are the master regulator of the immunity, it really disrupts all the help they were providing to all the other immune cell types. So really the lack of immune control is touching all the different cell types. And what I will try to do in the next couple of slides is show you how these different cell types are affected. So what we know about the immune system and the immune response in HIV infection is that HIV mutates very rapidly, and the immune system is not able to control it in most of the cases. Eventually, after primary infection, there is a balance that is reached between the immune control and the HIV replication in the body that dictates the viral set point and the disease progression. So the lower your immune control will be, the higher your viral set point will be, and the faster the disease progression will be also. So many studies have analyzed the immune system, and they have shown that this immune system is exhausted and dysfunctional. And not only those cells are dysfunctional, but the lymphoid tissue architecture, which is homing those lymphoid cells, is damaged. There's a persistent inflammation that persists in the tissues and in the CNS and in the gut. And overall, what the immunologists have shown is that the immune system really shows an increased premature aging in HIV-infected people. So for now, the only way to really stop the virus to replicate in people is to start antiretroviral therapy. But whenever we stop treatment, the virus is coming back at the same level as before starting treatment. So our goal, immunologists around the world, is to really try to design new immune intervention to reset this immune system that is dysfunctional and to try to control the HIV rebound after stopping ART. And as you can see here, our goal is to try to have HIV control without taking antiretroviral drugs. So there are very different ways to try to immune intervene on those HIV cure and really targeting all these cell subtypes. And we can first try to restore the innate functions by targeting innate cells. We can try to boost those cells and try to decrease inflammation. We can also try to restore the humoral responses and the B cell responses. And finally, we can also try to restore the cellular function as well. So I'm going to show you a little bit of the three axes that we can tackle to try to restore those functions. So the HIV infection activates the immune system and especially the sensing of this virus when it's replicating. So that leads to an activation of the innate immune cells that are secreting a lot of pro-inflammatory molecules that really inflame the whole system. So antiretroviral therapy reduces inflammation, but not to normal level. And the global immune activation that is driven by the virus is also enhanced by other mechanisms. The first mechanism is what we call the leaky gut, which is an inflammation of the gut-associated lymphoid tissues that then enables germs to enter the bloodstream and then cause additional immune activation of the immune system that sees all these germs coming in. The other part of the global immune activation is other co-infection that actually are happening because of that weakened immune system. And these other co-infections are actually also contributing to this global inflammation. And I think the next presentation from Dr. Cerruti will touch a little bit about on those aspects. So from monkey studies that are actually SIV natural host and are living with the SIV, they exhibit a viral replication, but they don't show a lot of chronic inflammation. So from these monkeys, we can really learn what are the mechanisms of immune inflammation, and we can try to also learn from immune studies what are the mechanisms of this inflammation and how can we turn it down. So some of the strategies that are currently tested in animal and in human trials are to change the bacterial environment in the gut to try to restore this gut barrier and try to avoid this leaky gut and this inflammation due to germs going to the system. Other strategies are to use anti-inflammatory drugs that have been used in other diseases to reduce chronic inflammation, and there is quite a few. And the last is really based on our mechanistic studies to develop new molecules to restore this innate function, and this is more in the middle term. So this is a couple of examples in that slide showing you the whole of some of the clinical trial in the whole clinical trial that are tested so far, just to give you a taste of what kind of therapies are tested. So these are two clinical trials ongoing using a probiotic to try to reduce the gut inflammation. There is also a termisartan study, which is a drug that is FDA approved to treat high blood pressure and prevent a heart attack, and Dr. Spudic is actually conducting a trial here using that drug. There is another drug which is called ruboxylitinib, which is a JAK-STAT inhibitor, FDA approved for rheumatoid arthritis. And there is another drug that is of interest, which is called sirolimus, which is an mTOR inhibitor, which is FDA approved to prevent organ rejection. And as you can see on the bottom graph is organ transplant that receive this drug compared to other drug to prevent organ rejection, cyclosporine and tacrolimus. They show actually these are HIV-infected, and the one that received this drug, sirolimus, show a lower reservoir size. So there's a lot of quick studies we can do because other infections or the disease have already drugs to reduce inflammation that can be used in the HIV-infected setting. And we will learn a lot in the next few years about these studies and how reducing inflammation can really help cure the HIV reservoir. In terms of antibody responses, we've seen for many years that HIV infection induces B-cell hyperactivation, changes the B-cell population, and also induces a lack of potent antibodies that are not able to neutralize the virions, mostly because the virus is mutating too fast. There is also reduced antibody-dependent cell-mediated cytotoxicity and phagocytosis of those HIV-infected cells. When we treat people with antiretroviral therapy, this B-cell dysfunction is not completely restored, and the people that are under therapy do not develop more potent antibody because there is no antigen anymore. So from some studies in HIV natural controllers that develop potent antibodies that are able to neutralize very different strain, and we call these broadly neutralizing antibodies, we can now analyze those broadly neutralizing antibodies, purify them, understand their generation, and try to really design strategies to use these more potent antibodies to try to eradicate the virus. So the strategies that are going to be tested and that started to be tested is to infuse monoclonal broadly neutralizing antibodies that have been generated from patients and to use them as therapeutic agents at ART interruption. We can also try to design new vaccine regimens to induce the generation of more potent B-cell responses and antibodies before ART interruption, and hoping that those new B-cells can control the viral rebound. And this is an example of a monkey study that was published last year in Nature, illustrating the use of monoclonal antibody for treatment interruption. So this antibody is called 3BNC117, and it was administered to monkeys when they have been infected and treated and suppressed under antiretroviral therapy. And the monoclonal antibody was given to those monkeys when they stopped treatment. And as you can see in the dark line, these are monkeys that didn't receive the antibody, and they all rebound very quickly within 5 weeks. What you can also see is that in the red line that is really moved towards the weeks in the x-axis is that the monkeys that received the 3BNC117 antibody showed a really delay in the viral rebound, and this is just with one antibody. So we are already thinking of using a combination of antibodies to try to really even stay longer without any virus rebounding. So these are very promising studies, and these are also going to be tested in humans. And the last part of the immune system that is dysfunctional is, of course, T cells. And many studies have shown that T cells are exhausted in both CD4 and CD8 T cells. The CD4 T cells that provide help cannot provide a good help to the other immune subset, including the B cells, to mature properly. And these cells are called T-follicular helper cells. And the CD8 T cells that are supposed to kill infected cells in the body are not able to secrete these effector molecules and are not able to kill properly these HIV-infected cells. Antiretroviral initiation do not completely reverse, again, this T cell dysfunction, like the inflammation of the B cells. And the new efficient T cells are not generated again under antiretroviral therapy because there is no antigen anymore. So from, again, these individuals, very rare, that are controlling naturally the infection, we've seen that some of them can develop really potent cytotoxic T cell responses that are able to kill infected cells and control viral replication. So we learned a lot about these natural controllers and how they can generate these T cells, what type of T cells they have been using. And so we can design new strategies to try to, one, revert the T cell exhaustion that they have using therapeutic agent to block negative regulator, and Dr. Chaumont alluded to that aspect in his talk. We can also try to use vaccine regimens to induce the generation of more potent T cells. And finally, and this is more in the long term, there are aspects to use gene therapy approaches to redirect the T cells to recognize and kill HIV-infected cells. So this is again an example in a very recent study published in Nature last year of a monkey study where they infected the monkeys, suppressed with antiretroviral drugs, and then used a vaccine regimen at 26 MVA with and without a TLR7 agonist, and then they interrupt treatment. And you can see those colors. So the sham, the control group is in the black line, and when the monkeys are receiving just the vaccine, in the green line, you can see already that there is a lower viral set point when the treatment is interrupted. But very promisingly, when those monkeys receive the vaccine plus a TLR agonist that serves as an adjuvant for the vaccine, you can see that you have a delay in the peak of the viral rebound. The peak is delay, it's lower, and then the viral set point is lower. So this is also very encouraging and showing you how the potential of having a good vaccine for therapeutic intervention and for boosting those immune responses to delay the rebound and to reduce the viral burden after antiretroviral treatment. So we know a lot of things about immunopathogenesis in those natural controllers, but really we don't know yet the immune correlates of remission in humans, in people that don't have the natural controllers genetic background. So there are few studies describing those post-treatment controllers who do not show the typical rebound in 14 to 21 days after treatment interruption. So what we know so far, and the only thing we know, is that they all started antiretroviral therapy early after HIV infection. But what is the part of the immune system that is maintaining these immune cells that are maintaining the virus to rebound? We don't know, and we really need to understand what are the immune correlates of this HIV remission to try to target our strategies. So why is it important to look at early treated in infection? So as I told you before, if you pass the peak of the viral load in acute infection, your immune system becomes dysfunctional. But we think that there is really a window of opportunity when we treat early enough where we could prevent this immune dysfunction to occur. And this is really an opportunity then to look at immune correlates of protection once we stop treatment. So such a study happens to be here in Thailand and has been really led by Dr. Anand Voranish. And this is a unique opportunity to really look at the immune responses in that cohort of people that initiate treatment before reaching this peak viral load. Treating early is not enough, and this is to show you that even in the monkey study, even if you initiate treatment at day 3, so you can see here in this slide the different days where treatment has been initiated at day 3, day 7, day 10, and day 14, you can see that those monkeys at day 3 didn't even see any viral replication in the blood. But when treatment was interrupted, they all rebounded. So treating early, even very, very early, is not enough. We need an immune control. But an immune control will be easier for us to try to eliminate the remaining reservoir cells if the reservoir is small. And this is a slide that I took from Dr. Chaumont in the RV254 cohort that shows that actually in those that have been treated very early, the reservoir is 100 times lower than the individuals that have been treated in chronic infection. So for us immunologists, tackling 100 times less cells, it's an easier job than going to the hardest part. So I think really the intervention in the RV254 cohort is really important because the reservoir is lower. And so what we have tried to learn from this study, and what I will try to show you in the next couple of slides, is how this immune system is preserved and why this is, I think, the best setting to then look at immune intervention in this RV254 cohort of early treated infection. So we looked in that cohort at the resting memory B cell compartment, and as you can see in this slide, if you are treated in chronic infection on the right, your resting memory B cell compartment is depleted compared to HIV non-infected control. If you look at the two first, I can show you here, the two first columns, these are the resting memory B cells. They get depleted also in acute infection early on in stage 1, 2, and even more in stage 3. But after 72 weeks of treatment, they really go back to normal levels similar to HIV uninfected. So we've shown already that actually the B cell compartment is preserved if we treat early in RV254. When we looked at the T follicular helper cell function in a co-culture assay in that cohort, we showed that actually the TFH cells in the stage 1, 2 had a higher capacity to provide help to B cells to secrete total IgG and HIV-specific IgG compared to the TFH cells in the stage 3. So again, if we have very early treatment, we preserve the T follicular helper cell and we preserve the immune system. On the CD8 T cell side, so we have two ways to look at HIV-specific T cells in acute infection. We can look at the rapidly expanding effector T cells by looking at the CD38 HLA-DR marker as illustrated in the cartoon up. And the other way we look at those cells is to use a tool that we call MHC class 1 tetramers that is able to stain specifically the HIV-specific T cells. And here I'm showing you an example of such a staining where all the cells that are here in this little box are actually stained for this tetramer that is recognizing a specific peptide for HIV, and then we can characterize those cells. When we looked at these effector CD8 T cells in acute infection in RV254, we see them appearing already in the earlier stages of infection in the stage 1, as you can see here. I clicked on the wrong button, compared to the HIV negative, and they expand over the course of the acute infection. And when we analyze further these cells, we've shown, and this is summarized here, is better than showing you a lot of graphs, that over the course of the acute infection, we really have a differentiation of early effector, transitional effector, and then full effector CD8 T cells. And what we have shown in that study is that those full effector CD8 T cells were actually able to reduce the HIV replication when treatment was initiated, and were also able to reduce the seeding of the HIV reservoir, and this was very important. We were also able to look at the persistence and the memory generation of these cells after treatment initiation, and we use this tetramer technology that we can stain the CD8 cells really long after treatment initiation. So this is an example of 3 patients. You can see on the top graphs the same donor that was stained in acute infection, 10 days after starting antiretroviral therapy, and then 5.5 years after this antiretroviral therapy was done. And we can follow longitudinally those cells and look at the memory quality. And again, to summarize the data we generated looking at those memory T cells, is that in contrast to the memory that is generated when you treat in chronic infection, where those memory cells are exhausted and they don't really recover their function, we actually observe a preserved memory when we treat in acute infection. So that is really for us the best setting to have, if we have a preserved memory, to have immune-based strategies to boost the preserved immune system. So our task now is to test different aspects, as I presented before, the different strategies in these early treated patients to try to boost this immune system and to reach an immune control after antiretroviral treatment interruption. So to summarize, what we think we will do in the next few years is to, one, preserve the immune function and limit the HIV reservoir size by treating early. And once we have that, we can now try to eliminate those reservoir cells and enhance immune control by different means. So decrease inflammation, inject potent antibodies, and use and boost TLB cell responses using vaccines. And we are testing all these strategies one by one and see what their effect is. But most probably we will need actually a combination of those immune approaches to reach our goal. And you will tell me those are really good for people that we are able to capture in the early stages of infection. But once we have a signal and we can really show that we can enhance immune control by some of those strategies in early treated, our goal is really to be able to apply that to even chronic infected people that have been treated in chronic infection. And in that population, what we are going to do is to use the same techniques and the same tools that we have been testing in early infection, but we have a higher bar because the reservoir is really higher. And one more thing we will have to do for immune intervention is actually restore or reverse the immune dysfunction. And that will be another addition that we will need to be combined with the other approaches. So a lot of work needs to be done, and as Nicolas has a lot of work on the kicking of the reservoir, the immunologists have a lot of work to try to test all these strategies, but eventually we're optimistic that we can have some improvements. And with that, I will thank the funders, all the participants for the study, my lab in MHRP, Dr. Anand Voronish, and all the other collaborators in US and in Thailand. Thank you.
Thank you so much, Lydie. That was great. We have time for one question. Anyone has a question for Lydie? Okay, please go ahead. I think you're the one immunologist in the audience, which we like you a lot. Please go ahead.
Hi, I have a quick question regarding the CD8 T cells compartment. So for your acute study, have you tried to stimulate those CD8 T cells with peptide to see what's the functional profile of those HIV-specific CD8 T cells? Are they polyfunctionals, and what type of cytokines they produce?
Yes, so we have actually looked at the responses by cytokine secretion in acute infection, and we see over the course of the acute infection a loss of this ability to secrete cytokine and to respond. So we know that very early on they have this capacity to secrete cytokine, and they lose it among the course of the acute infection. But also after treatment, we know that those memory cells really look more like memory cells that we can find in influenza or in other memory cells, more than the HIV-specific cells that are found when you treat in chronic infection. So we didn't do this experiment on the treatment because the number of cells we analyze is very, very tiny. But I would, if I could bet, I would say that they would be really more polyfunctional from what we've seen so far.
And also, do you think that you'll see the same thing in tissue as compared to what you see in the blood?
We actually have some data that, yes, at least we looked at lymphoid tissues, and the responses are actually quite surprisingly very similar.
Okay.
Okay, very quick question, please. Thanks.
Yeah. Emilio Fumero, VIV Healthcare. Thank you for your elegant presentation. I just wonder if you can comment on a recent paper using an integrin monoclonal antibody that blocked the trafficking of T cells into the gut, and there was a surprising viremia control in the animal models?
Sure. There is a recent study that was published in Science that used actually an alpha-4 beta-7 monoclonal antibody, and the mechanism is really not clear at that point, and the community is really engaged in understanding why the treatment with this antibody was really drastically reducing the viral burden and then eventually lead to the control of the virus. So there are a couple of things that can happen. You know that the virus is secreted from cells that are infected, and the virus could be having at the surface this molecule and could be blocked by this antibody. The other explanation could be that it blocks the trafficking to the gut tissues, and it changes the homeostasis, or if you will, the balance between those compartments. But really, so far, we don't have any mechanism. But we like any signal, because whenever you can control groups and you have a difference and an impact of the virus rebound, then we can dissect the mechanism and then we can try to repeat it. And so I can tell you already that some human studies are in the process. So we learn a lot, but really the field has generated a lot of exciting data recently, and it's moving really at a really increasing pace. So I'm sorry I cannot give you any mechanism of action, but we will know for sure in the next future what it is, and we try to reproduce it in humans, because this was in monkeys.
All right. Thank you so much, Lydie. And